Is there a Kazem? Can we pull up the first slide? All right, welcome everyone. We want to get started on time this morning because I know we have a packed schedule. So welcome to the live surgery transmission. We have two surgeries for your interest today, so hopefully everyone will find that very interesting and educational. So before we start, I'm Dr. Shirazian. I'm going to be moderating today's session. I'm the director of the Center for Fibroid Care at NYU Langone. And I would love our esteemed panel here to introduce themselves. So we'll start here.
Good morning, everybody. Welcome to the first session of today. My name is Kazem Nouri, and I'm specializing in reproductive medicine based in Vienna, Austria.
Morning, everyone. My name is Ferreira. I'm professor at the University of Porto in Portugal, and I'm the chair of the minimal invasive surgical unit in Porto University Hospital. I'm very happy to join this session.
Very lovely good morning, my dear friends in Vegas, famous of shows, and today we have a wonderful show, but not in a theater, in the operating theater. I'm Osama Shawki. I'm a man who spent 9 months of my life inside the cavity of the uterus, and when I came out, I decided to be back as a hysteroscopic surgeon. This is the only thing I do in my life, hysteroscopy. Thank you.
Good morning, everybody. My name is Radu Apostol. I'm a fellowship-trained minimally invasive gynecologist, currently practicing in Brooklyn, New York.
Okay, thank you all. Thanks for being here. All right. So our first live is with Dr. Hawkins. Dr. Hawkins is based out of Atlanta, Georgia. She's a board-certified fellowship-trained MIGS surgeon. She's an expert in advanced laparoscopy, robotics, and hysteroscopy for fibroids and endometriosis. And she specializes in patient advocacy. She speaks frequently in the media. She's an advisor and national speaker for multiple industry organizations, and she's here today to show us her live. So just briefly, I wanted to present her patient case. So this is from her. So she has in the operating room now a 50-year-old para-1 diagnosed with fibroids in 2019. She has 2 small fibroids that initially they just managed with hormone therapy and conservatively. And so over time, the patient has progressively had worsening pelvic pain, occasionally intramenstrual bleeding. She had tried an IUD, but her symptoms persist. This is some imaging. This is her ultrasound imaging, which they started with, which shows the fibroid, a 4-centimeter uterine fibroid. We'll see the MRI next. You'll have sort of a better visual of it there, and some ovarian cysts as well. Here is the MRI images. You see the fibroid both anteriorly and posteriorly, sort of between that endometrial cavity there. And another view of the MRI. So our clinical considerations are the patient has these symptomatic fibroids and persistent pain. She has some ovarian cysts. She had tried medical management, but failed medical management. And here we are now in the operating room. So she first started with a hysteroscopy to see if there were any fibroids in the cavity. She's going to show us laparoscopic radiofrequency ablation, possible lap myo if there are any small fibroids on the outside. The goals of surgery are symptom control and evaluation of additional pathology. Okay, let's go back. So I guess let's go to the live. Dr. Hawkins, can you hear us?
Hello. the bed up a little tiny bit. Hey, good morning.
Good morning. How are you?
Good. Excellent. Excellent.
We are excited to have you. We're live in Las Vegas.
Let's see. What view can you guys see right now? I'll start with that.
I'm not sure what I'm looking at. Maybe down a trocar?
Okay. Got it. So possibly down a trocar. I'm actually going to start with the hysteroscopy. What we did was, in the world of live medicine, we know that sometimes you can get in the belly and be like, oh my God, what's going on? So I wanted to get into the abdomen first, take a good look around to make sure that I didn't waste everyone's time, because she had a hernia repair. She had two, and the second one was with mesh. And as I suspected, she does have a significant amount of adhesion fibroblasts. But I was able to take them down, get my other trocars in. So I started the surgery there, and then I desufflated her so we can go down and do the hysteroscopy together. And then when I go back up, we'll complete it. Let me have 10 pieces of food in here, please. So I'm going to have the team put my hysteroscopy view up so you guys can follow me here first. This young lady, she's 50, and she is 100% a patient that wanted uterine preservation but has very symptomatic fibroids. I'm going to use a medium V pair when the time comes. 100% wanted some symptomatic relief, but wanted to keep her uterus, right? By her own right, that is fine, especially since she has reasonable enough fibroids to accommodate some more conservative options. So you guys saw the workup that I was able to do. Put my hysteroscopy view on the screen. Shonda. Is Shonda over there? Can you put my hysteroscopy view up, please?
Yes, we just reviewed the case. We saw the MRI also, Dr. Hawkins, and we saw what looked like 2 fibroids, but probably you'll find more.
More, always.
Always.
And so her initial ultrasound, she had an SIS that was done, and it showed that she might have intracavitary fibroids, mucosal fibroids, and that's one portion of anatomy that we never want to miss, because of course that is what usually leads to the most symptomatic bleeding, heavy menstrual bleeding for patients. So I do a lot of concomitant procedures, a lot. And most of my radiofrequency procedures will include a hysteroscopy, especially if I have any concerns about this intracavitary anatomy. And I don't know if you guys can see
we're looking
at the hysteroscopy view. Right?
Yes.
But not too bad, actually.
Looks good. Yeah, we see the ostia pretty well. It looks like a
the
pretty
ostia
clear cavity.
pretty well. Yeah, it looks like a very fair cavity. Nothing in the MRI, which is why we also love MRI, said that her cavity was pretty clear and she didn't have an intracavitary lesion. Let's actually drop the pressure a little bit. So sometimes when we drop the pressure, we can see.
And Dr. Hawkins, what do you usually use? We have a panel up here today too. Just out of curiosity, what do you usually use for hysteroscopic resection?
So I usually use a MyoSure device. I know there are a lot on the market, but MyoSure by far is my favorite. I actually trained in fellowship with a resectoscope of monopolar, mannitol resectoscope. When I came to one side, they said, let's try not using the monopolar. I used bipolar for a while and then learned how to use a MyoSure, and it has been quite lovely. So for the most part, even with my large calcified fibroids, I can use a MyoSure XL and get them out.
Perfect. I'm going to ask our panel, since we have a panel, I'll ask them about their approach while you keep moving for the lab setup.
Sure.
So just curious for hysteroscopy, because I know there's a lot of variation in hysteroscopy in the world, and people use different things. Just curious if anyone wants to tell us about what they usually use.
Well, you were talking about the MyoSure, and we have to clarify that this tissue removal system, whether MyoSure or the IBS or the TrueClear, they came for the market initially to deal with the small pathology. But with the development, they can do larger size. However, they have a big limitation for deep intramural part. So not just because you have a gun, you mean to go to shoot everybody. So you have to be wise for your choice. Okay, for deep intramyometrial myoma, the standard resectoscope is good. But there is some also, I want to highlight the difference between the bipolar and monopolar. There is a lot of fears from monopolar because of the fluid overload with the glycine. However, it's not only about the fluid deficit. It's about the duration of surgery, the volume of fluid used, and lastly, the pressure. So there should be a balance about how much time you operate. For monopolar, it is safe if you can finish in short time. The bipolar, there is also technical point. There are two kinds of bipolar group. The one like in the car stores, the loop is double. There is up curve and lower curve. And this is confusing because the tissue gets stuck in it. And then there is the standard only one loop, which is the same like monopolar, which in my opinion is much better. There is no concern about fluid overload so long you measure the inflow, the outflow should not exceed 1 liter for glycine, it should not exceed 1.5 to 2 liters in saline. So this is play safe.
Dr. Hawkins, we're just talking about all the various types of hysteroscopic devices used globally. Oh, it looks like you're in the pelvis. Okay, I guess we're going to go back to the pelvis now. So what type of uterine manipulator are you using, Dr. Hawkins?
I use the V-Care uterine manipulator. Take out some of the tuberculosis. I only do like 26 is more than enough for me. Thank you. And I'm glad that you mentioned that. So my setup down below, you don't have to use a manipulator for radiofrequency laparoscopic radiofrequency ablation. However, I usually do because I love the manipulation that I can get, especially to get to those lower uterine segment posterior fibroids. You can just do a lot yourself in the movement to get your ultrasound, which I'll show you in your handpiece in the right plane. The other reason I love to use a manipulator is because I see the 10 cc's of fluid inside. And with that 10 cc's, I'm going to be able to see it on the ultrasound. So you'll be able to see that black circle, just like we do when we see fluid in the bladder or anywhere else on our ultrasound view. You'll be able to actually see where your cavity is, especially if you want to be careful or make sure you're not missing those fibers that are very close to the cavity. So we have a uterine manipulator, of course, my Foley, but some surgeons will do this with just a snap drum on the cervix and use that to manipulate. Some surgeons will even do this 2 times. I definitely like my patients to know that me again, because I like that easy access to my manipulator. So let's talk about my abdominal setup, since you guys can see that portion, and then once I start my laparoscopy, we'll have a laparoscopic view and ultrasound view. But while I have you here, I use a 10mm scope. One of the beautiful things about radiofrequency ablation is these patients can go home today. They can get back to life in a week. I usually will say probably limit strenuous heavy lifting activity for 2, no more than 3 weeks to see how they feel at 2. And that's because I use a small scope here. So I use a 5mm. Of course, you're going to do whatever's comfortable to you, whatever you usually would do. But I just use the 10 because I'm a fan of a 10mm, just for that excellent visualization. But I downgraded to a 5 because otherwise this procedure doesn't require them to be down for very long. You have to use a 10mm at your suprapubic, and really it's not just suprapubic, but at the fundus of the uterus. So you want this lower abdominal trocar to be, I usually put it right in the middle. That's how we teach it. And then you want it to be at the fundus of your uterus. And that's going to be extremely important once you guys see how I manipulate. And this has to be 10mm because you have to be able to fit in this ultrasound. So let's go ahead and see if you guys can get this ultrasound view. Move this over a little bit more and move this right to my foot, and then we'll be perfect. And then you guys can turn the lights down. We can rock and roll.
So another question, Dr. Hawkins. You're laparoscopic right now. I know these procedures can also be done robotically. Any thoughts on one or the other?
Absolutely. So again, those concomitant radiofrequency procedures with either like a robotic approach plus the radiofrequency, either Sonata or Acessa is certainly not unheard of. Certainly some doctors, that is how they do all of their cases, because they would go, for instance, with this anatomy, they would go in here and robotically remove this posterior fibroid and then use their Acessa to treat the more intramural fibroid. And I do that too. It really depends on the symptomatology of my patients, what's bothering them the most. And obviously the anatomy. If she had a huge anterior fibroid that was pressing on her bladder, sometimes it is beneficial to just go ahead and remove that. The great thing about radiofrequency, which is very different than, say, UFE, which is the hypoxic necrosis and shrinkage, that other shrinkage option that's out there for fibroids, is with radiofrequency, we're actually softening the fibroid. So even with this posterior fibroid, if she's having any discomfort posteriorly, that softening of the fibroid going from more of a soft ball consistency to a marshmallow really makes a difference for the patient. As a matter of fact, the first symptomatology that patients will usually describe improves after radiofrequency are things like back pain, frequent urination, constipation, discomfort with intimacy. It is those both symptoms from these fibroids. So even when they have them in this anatomy, I'll give them that option because I know it will soften for them. I think of it in my head, and this is not scientific, nor is it what's written in the papers, but I think of it in my head, maybe I can get you back to the symptomatology from about 2 years ago. With the shrinkage and the softening combined, how were you feeling with the bulk symptoms 2 years ago? And let's try to aim for that.
And how do you make the decision? So this looks like about a 5 centimeter fibroid or so. How do you have a limit as to the size in which you would offer RFA?
Sure. So this is a good place to start. So on my screen on the left side, you can see at the top portion, that's gonna be my handpiece, which when I open that up, it'll light up and we'll be able to go through it. My ultrasound portion, every green dot on the screen, and hopefully that screen is pretty big for you guys, is the dimensions of the fibroid. So regardless of what I thought the size of the fibroid is, sometimes I get in here and I measure it even better. And I do document all of my measurements, location, and number of fibroids, of course. So for this particular fibroid, it's posterior, exophytic, and it is 1, 2, 3, 4, almost 5 centimeters, like he said, by 1, 2, 3, 1, 2, 3, about 3.5 centimeters if you're looking at the full capsule. In the studies, in the IDE studies, the fibroids that they did were up to 7 centimeters, right? So, and the largest uterus was about 16 centimeters. So I usually will stay within those parameters. And this one too. So the first thing I always do is to map the uterus and see how many fibroids I have. It's got to be at least what they show me on imaging, and sometimes I'll find more. This one is going to be right lateral intramural, and it is 1, 2, 3, 4. Again, probably like 4.5 centimeters by 1, 2, 3, by 3 centimeters. Let's see if there are others. So I usually will stick to about 7 centimeters. I used to do them bigger. I think we're cowboys when it comes to medicine, especially when you technology, we'll try different things. I started doing Acessa in 2019. I've done over 300 procedures now. And at that time, I did it in even bigger fibroids. But now I pretty much stick to it. Now that I see how the technology works, I see what gives my patients the best symptomatic relief and where they're the most happiest. And it's somewhere around there. If I have a 10 centimeter fully transmural, fully engulfed by myometrium fibroid, then that I might do as well. But of course, that is, outside of the IDE study. So let's put in our handpiece and then we can keep talking while I actually start to wait.
Yeah, let's do it. It looks like there are a few small ones interiorly, correct?
Yeah, and if I find any that are pedunculated.
Why not the myomectomy in this case?
Yes, I was just gonna ask
Sure.
that. Okay, we have a
You're
question.
just saying the same question. It's an easy hump.
Now, it's interesting to see these alternative approaches to fibroids, radio frequency, microwave.
Absolutely.
And why this
go ahead.
approach?
This approach was actually presented to the patient along with myomectomy, along with hysterectomy as well, because she's 50 and she, declined hysterectomy, but of course I talk to patients about everything, even USP. And for her, the thing that is usually, for her and for most patients that choose this radiofrequency ablation type of procedure, she was very intrigued by the turnaround time, how quickly she can get back to life. She's a single mom. Her son lives with her and they wanted to get back to life essentially. She works and she doesn't have a lot of time to take off, so she can be back to work next week. She can be back to activities very quickly. The downtime is significantly different than if I were to do myomectomy, or even if I were to do a hysterectomy for sure, and limited some of her ability to lift and exercise and do those things. And there's a stark difference when it comes to even pain and their recovery process. I have patients even that will say, I need an option where I don't have to take narcotics. Sometimes it's as simple as that in their decision making, but I presented the options and this was the one that definitely was more feasible for her.
We have a question from Dr. Radu.
Yes. Good morning, Dr. Hawkins. Thank
Good
you
morning.
for allowing us to watch such an interesting case. I was just wondering, preoperatively on the MRI of the pelvis, was there any
Yes.
concern additional to the fibroids that there might be
Yes.
some adenomyosis present?
Absolutely, yep. So that is one of the things I actually counseled this particular patient about significantly, because I had concerns when I looked at her ultrasound, even though it wasn't noted, for the potential for adenomyosis. And I told the patient her surgical options around that were somewhat limited, as we know, mainly to a more definitive hysterectomy approach. But remember, this particular patient didn't want that. I would say that my only failures, and the way I measure failures is either continuation of symptomatology, and especially if it brings the patient back for a second procedure, are in patients with adenomyosis. And I even shared that with her as well. So this patient does have signs of adenomyosis on her MRI, as I suspected on her ultrasound. But again, wanted to see, can we treat the fibroids? Maybe that would give me a significant enough improvement on my pain and discomfort. Even though we talk about pain, not necessarily being associated with her fibroids, but her heavy bleeding. And then she said, I might not bleed like I'm 13 again, but if I can at least turn the faucet down some, I might be able to have a satisfactory symptomatology to get me through to menopause. So we had a very, very, very detailed discussion. And also, if she decides in 2 years it's not good enough and she wants her hysterectomy, she's not totally opposed to it as another procedure. But this is her first procedure on her uterus, and she just did not fare well to that option. But she does have adenomyosis.
Thank you very much. And I think this is also important to underline the importance of preoperative counseling,
Absolutely.
as you mentioned. So thank you for highlighting that. Thank you.
Okay, so I want, Dr. Hawkins, yeah, so I think RFA, just to summarize that, sometimes can be a good tool sort of as a transitional procedure until menopause. So it sounds like in this patient, maybe that was also part of the decision-making. I was hoping you could talk us through what is happening on the screen, because for those who are not familiar.
Absolutely.
The ultrasound, we're seeing the ultrasound views sort of on the right of the screen right now. And then we're seeing the needle go in towards the left. So yeah, maybe explain how through the planes you can see the needle being positioned and sort of what goes into that.
Sure. Yes. So at the top of our screen, we see that yellow bar. That's going to show our handpiece. The handpiece is the actual portion that's doing the work of the radio frequency. It has this needle array, and the needle array has temperature sensors on each tip. And so when I started, you saw that I actually used a coag mode to go into the myometrium or the serosa, because this fibroid is pretty superficial, and line myself up with my ultrasound view. That purple paperclip is coming from my ultrasound, and that's the Acessa ProView system that's going to give us good visualization of the ultrasound, but also show us exactly the track that we're actually going in, because fibroids are three-dimensional, right? So they're not just going to be flat by any means. Once I get myself aligned with the ultrasound and the handpiece together and decide where I want to be in that fibroid, I get myself pretty close to the capsule. The thermal spread for this technology is about 1 centimeter. Once I'm able to get myself close to the capsule, I open up those needle arrays. On this actual handpiece, it's just a purple slider that goes up and down, and I easily see that with my thumb or forefinger. Once I open it up to a distance that I'm comfortable with, because it's inside of the capsule, and you can see I've chosen, can you circle that for them on the screen, please, that fibroid to the capsule? I've chosen to come right up to the capsule, and that's my comfort zone. And then I also will look at the ultrasound itself in about 3 or 4 different angles to make sure I'm within that capsule and begin my ablation. So on that top screen, 1.1 centimeters is the length of my needle array that's open inside of the fibroid. I'm getting my temperature up to 95 degrees Celsius as a therapeutic temperature for ablation for cellular death and sustained cellular death, that coagulation necrosis. And it's telling me, based on that 1.1 centimeter needle array and the essential volume of fibrin I'm trying to actually treat for cellular death, I need to do this for 48 seconds. And then once I get my foot pedal, because we're always in control, it'll start to time it down. So what you're seeing here in that white, that hypo or co-wave look on the ultrasound is real-time radiofrequency ablation and coagulative necrosis that's happening with the tissue. You can actually sometimes even see that outpopping of fluid and gas bubbles as it starts to die. So it's also a good way to check and see what areas of the fibroid have you treated. Right, so Dr. Shirazian can show you guys there that darker portion of the fibroid that's closest to my handpiece. I'm gonna try to make this high level. If you guys ever come into the OR with me or watch some of my other observations, we get very granular. But high level, that darker area closest to my handpiece, I know that area I haven't treated. So let's actually go and treat that area as well. Because I wanna treat, I aim for 100%. Dr. Bruce Lee, the inventor of this technology, will tell you, you wanna get at least 80%. And you see, before I was center, now I'm moving myself a little closer to the surface. I'm just gonna get right into that darker area. You see that? And that yellow is always tracking where I am so I can be safe. And my area of ablation is gonna be even smaller because I'm right up against that serosa.
How many zones of treatment do you usually do for a 5 centimeter fibroid?
Sure, usually a 5 centimeter fibroid might take me anywhere from 3 to 5 ablations. And sometimes it's dependent on the configuration. Is it more of egg? Am I going? I usually try to treat centrally and go as far on that trajectory as I can and then work my way back around the periphery. So this, I don't know if you guys caught it, it just timed out on the machine and it went red and it said that the RF ablation zone is fully desiccated. So it's telling me that this area of this fibroid is treated. Because remember, we have temperature sensors on the actual needle array. So it can tell when an area has been treated already. And so most of this is grayed out. This fibroid is fully treated.
Great. So I'm gonna go back to the panel, Dr. Hawkins. Any experience with?
I'm just asking, is there any comparative studies between this technique and the HIFU, which is both ablation technique, but HIFU is much more less invasive? Any difference in the outcome? And another question to Dr. Nouri, because we have an IVF specialist. What is the prognosis of such approach regarding fertility? This is very interesting to me to know.
Let's do that as 2 questions.
Yes, okay, all right.
So the first one
is comparative studies between radio frequency ablation and the HIFU or similar, probably embolization as well.
Anyone take that?
Yes, these alternatives to approach fibroids or even adenomyosis are interesting. They're ablative, as Osama said. In fact, I think ultrasound, focus ultrasound, like HIFU, it's I think in terms of outcomes is similar. It is a bit more expensive.
It's a lot, and it's more expensive, and it's more resource intense.
Logistically also, and then microwave also is an option. Radio frequency we have experience in our center, but more transvaginal approach.
We'll talk about that.
In such a way, less invasive. But I want to listen to the opinion of the surgeon concerning this approach with a single probe in comparison with multiple probes like the Sonata.
Yes, so I do both procedures. My institution has both procedures, and actually my partner does a lot more sonatas even than I do because she tends to see her patients a little bit younger, in their symptomatology, meaning earlier when their fibroids present to them and start to cause discomfort or issue. So she can do some of the smaller ones. They're more intramural or type 3 submucosal, and Sonata is quite lovely. Of course, the less invasive we can be as minimally invasive surgeons, the better for everyone all the way around. I just want to highlight this purple paperclip is really, really long here, and that's because my handpiece and my ultrasound are lined up extremely parallel to each other. So then you get even better accuracy as to where you're treating the fibroid. So I usually would just line myself right in the middle. So Sonata for me, if the patient is a good candidate, it has a bit of a more narrow candidacy. But if the patient is a good candidate, then obviously having them do no incision and then do so and be able to essentially behave just like any other transcervical or hysteroscopic approach where their downtime is 2 or 3 days. And they're again getting that same radio frequency technology, so same outcome, very similar outcomes is definitely a sure bet. So Sonata, in comparison, same technology, just a different approach and way to do it.
I personally actually do a lot of Sonata as well at NYU, and it is something that I use frequently for smaller fibroids, especially those that are, between the submucosal space and the intramural space, resection plus radio frequency reporting.
And in terms of surgical time, Sonata versus single probe.
Yeah, I think Sonata is more for those type 0, type 1, type 2, the ones that are sort of closer to the
The
cavity.
fact that having multiple probes makes the procedure shorter, or?
I think
I don't have experience with Sonata, that's why.
Yeah, I think it's a really great technology, but I think there are limitations.
Similar.
Limitations are
Yeah, similar to
no
needle probes though. So you're still getting a needle array with Sonata as well.
You're getting a needle array. It's the same. I'll show some slides actually on the RFA techniques after this, but it goes in vaginally. The ultrasound is that intracervical and then intrauterine, and it has the same array.
And both belong to ology, no?
Both now belong to Hologic, yes, who's here today. Okay, so are you finding another fibroid here, Dr. Hawkins?
Yes, so now this is our right lateral intramural fibroid. And you can see again, if we can trace that capsule for them on the screen, that would be great. And then you can see that I'm right at the edge of that capsule, furthest away from my ultrasound. So that's the anterior portion, and then I'm just gonna look there as well, just to make sure I'm safe and I'm within it. You can see I'm a little beyond it, not as concerned with her, given her age, but I like to try to be within the capsule. So get myself in the capsule and then we can begin our ablation.
So actually, this is the third fibroid you're ablating.
This is
that
the
right?
second fibroid.
Oh, it's the second
I'm
fibroid,
ablating,
okay.
Of 2 that I see, yes.
Got it.
We did, I think, 4 ablations of that first one, but this is the second ablation of the second fibroid. Correct. And then you guys did see the cavity there.
Yeah.
That's why I like to use a little fluid.
And this does look small and deep, actually, intramural.
Yes.
So.
This one is a bit deeper for sure. The great thing about the radio frequency combined with this ultrasound can be, for both Acessa and Sonata, is that visualization and that ability to the fibroid that you can actually see. So even the intramural, even the small fibroids, the 1 centimeter fibroids can be treated with radio frequency using Acessa. You can treat without even opening the needle array. And do just a manual ablation of that tissue. That's more of a myolysis than the radio frequency, but you're still getting some good tissue damage that's gonna kill the actual cell.
Also,
And when you get that, go ahead, I'm listening.
Also, I want to listen your feedback concerning the use of that laparoscopic ultrasound probe. Do you find it interesting in comparison with the transvaginal or transrectal or even transabdominal ultrasound approach?
Yes, so I think the learning curve in this procedure is in the ultrasound and getting used to it. I do a lot of my own ultrasounds in the office for my fibroid patients just because of the large population of my kind of use it in my counseling. So it wasn't difficult for me to transition to this intrauterine ultrasound. They did studies to look at the accuracy of it, of this intra-abdominal approach as opposed to transvaginal approach in the MRI. And they found that we found 1.4 more fibroids in the MRI and almost 2 times the fibroids that we find with transvaginal ultrasound. Definitely more accuracy. As you can see, once you kind of get used to the look of it, it is an ultrasound. It has on that right side of the screen your depth, your frequency, your gain, your focus. You can adjust it to get a finer visualization. You can zoom in on the anatomy to make small fibroids larger on your screen for even better accuracy. It is an ultrasound. If you can look at a baby's head and measure a baby's head that first day of residency, you can do this ultrasound.
As that ultrasonic laparoscopic probe as a Doppler?
No Doppler. It does not have a Doppler approach. I don't know that I would need it for the for what we're trying to do though. So it does not have a Doppler.
Would you find it interesting to have a Doppler?
I don't think so. I don't think it's necessary. I can actually see vasculature that looks like a vessel. And remember, my goal is to stay within the confines of the capsule of this uterus. So a Doppler possibly could be helpful if I was trying to do a neck flow pathology. Certainly want to make sure that I'm not in any lateral vasculature, but that's the reason that we're so insistent on checking to make sure you're within the capsule before. And the machine actually, if it senses that you're in that vascular space, which is going to give a different type of feedback to the tips that are very sensitive, it actually will not start the radio frequency of movement. If you're outside of the serosa in the intraperitoneal space, it will not start the radio frequency. So it has a good amount of safety measures to it as well.
Are there any audience questions? If anyone has a question, they could just flag me down. Oh, we do have some questions. Okay. If you want to step up, I can repeat it so Dr. Hawkins can hear it. Do we have a mic? And then I want to go back to the pregnancy question, but we'll take the audience questions and then we'll go to that. I know that's always.
I'm eager to hear Nouri opinion here.
We'll let him.
Good morning, Soyini. This is William Morzel.
Hi,
Can you hear me?
Dr. Morris.
I am so proud of you. Let me start with
Thank
that.
you, sir.
Question for you. I understand you puncture in the serosa, there's not much bleeding, but have you considered doing any sort of pre-procedure blood loss reduction, like vasopressin or Cytotec? The rationale
Yes.
behind it is whether the coagulation necrosis will settle up quicker if there is less blood flow into the uterus and fibroids.
Great questions. All questions I asked when I started to do this. So what we have found is that not so much Cytotec, but I think will be just fine. However, vasopressin, because it's constricting the vasculature, it changes the look of the fibroids and the anatomy on the ultrasound. So it can make it a little bit more difficult to actually see the capsule of smaller fibroids. These bigger fibroids very much are going to stand out. But I've done this procedure and have ablated sometimes 10, 12, 14 fibroids, and I want to see all of the anatomy. When you use vasopressin with that vasoconstriction, it does change the way that you can visualize it. So I would rather not compromise my visualization and my ability to actually get all of the fibroids. The theme in my OR is no fibroid left behind. We want to get all of them. So we don't use vasopressin. And as you can see, my blood loss is quite minimal. So I don't know if it theoretically would help with the coagulative necrosis, especially because, you know, what you're trying to compromise here is not the vasculature. Again, very different than that hypoxic necrosis that we're looking for with uterine fibrosis right here. We're only trying to teach the tissue at hand, and that's going to get that cellular material to come out, that water to come back out, and that shrinkage is going to be just leaving you with a collagen. So I don't know if compromising the vasculature would assist with that in any way. We want good vascularization to the rest of the myometrium for these patients.
Okay, thank you. All right, we're going to go to the panel to talk a little bit about RFA and pregnancy because I know it's always top of mind. We get lots of questions about it and the data is limited.
So first of all, let me also thank you for letting us, you watching or you operating so beautiful. I'm Dr. Nouri based in Austria. So to answer your question, I myself, we don't have in our center this kind of equipment. As far as I know, in Austria, there are 3 centers and they are doing this also for infertile patients. And the data I have seen are very promising. But basically, coming back to your question, fibroids and infertility, we can write books about it. It's not the proper time to answer this question. Basically, in the last years, type 1 and 2 fibroids before embryo transfer should be removed. What we know now, according to data, even intramural fibroids, type 2 till 5, they can also be a problem. So we have to think about removing them as well, even there is no deviation of couple uterus. As a reproductive medicine specialist, we don't want to have scars. So our first choice would be always to use for this kind of fibroids, the type 1 and type 2. Type 2 is always a hysteroscopic surgery, but for these kinds we use medications and try to start the embryo transfer process right after 3 months, 6 months of treatment. Or sometimes you have to do surgery. So I have myself a question. This is a 50 years old woman. And as far as I understood, she doesn't have any wish to have a child anymore. Is it correct?
Yes. So I'll be honest. We had a long discussion about this in the office. She does not wish to actively attempt to have a child. However, she would not like to lose the ability to have one if God so were to bless her. So again, that goes to why
it's a very common category. She wants to maintain the uterus, but she doesn't necessarily want fertility.
They love their uterus.
Okay.
It's a symbol of her divinity.
I understand this part. I understand this part. My question is, right now in Austria, we do a lot of opportunistic salpingectomy. That means when we perform laparoscopy, if the patient doesn't want to have any children anymore, we should recommend to remove the tubes. Is it the same process in USA?
Yes, and I offer that to her as well, especially for my older patients that the conservation of their uterus has more to do with, I just don't want the downtime of the other approaches. And they have fibroids that are amenable to actually responding very well. They don't have adenomyosis, they're perfect candidates. Then I do offer the salpingectomy for, especially, to minimize or reduce their ovarian cancer risk. That alone sells it for most patients. And then of course that sterilization portion too. She's not actively trying to get pregnant, but again, does not want to do anything that could potentially compromise that for her. So she declined removing her tubes, but I did offer it to her. I agree with you 100%.
Okay, I think there was another audience question. I think we'll take just a few more and then move on. We have some RFA slides too that we're going to show, Dr. Hawkins. Okay, what do we have next?
This is a patient. I just had a quick question. Seeing as this is a procedure that sounds like it's fairly new, in terms of a patient going to an OBGYN that isn't familiar with this, would you find it prudent to recommend maybe an interventional radiologist? Is this a practice that might be expanding across different domains? I just wanted to ask, since it does seem like a technique that might be unfamiliar to a lot of the general population of OBGYNs, and I understand we're going to see an interventional radiologist speak today. I just thought I'd talk about that as well.
That's a great question. Let me take a stab at it first, Dr. Hawkins. So RFA technology has actually been around a long time. I think the problem is that sometimes when patients go into their OBGYN, they're not always offered every option that exists. And this is something that we'll talk about during the day today. So RFA has already been shown to be safe and to be effective. It's not actually as new as you think. It's been used in Europe far longer than in the United States even. And it is safe and effective, but I think the problem here is that there's not a great understanding of it across the country and even maybe across the world. And so that's why we're having these conversations. That's why we have these conferences. That's why we encourage patients to seek out physicians that give them every option. And so, yeah, to answer your question, and the interventional radiologist does not perform these procedures. It's your gynecologic surgeon that typically does.
You can go first.
Dr. Hawkins?
I just want to engage the audience with us, okay? Regarding the benign simple pathology like a fibroid, okay? I'll give you two options and raise your hands, okay? Simple fibroid. What's your choice? Just kill the pathology and leave it in place, or to remove it out of the body? So those who agree, kill the pathology and leave it, raise your hand.
I mean, I think the problem here is that there's more decision-making that goes into that question. Because the other thing I will tell the audience is when you go in and you surgically remove fibroids, often we counsel patients that they need a C-section for delivery. And many women do not want a C-section for delivery. They don't want to automatically be in that cavity. So actually treating smaller fibroids with RFA is not only less downtime, better recovery, but potentially gives a woman more options.
Is it absolute indication for C-section after myomectomy?
If we remove a lot of fibroids, then yeah, typically.
Yes.
And we can talk about that, but typically that's how women are counseling.
So if you consider sometimes patients, honestly, for me, it comes down to, like I said, this patient was counseled on all of her options, including a myomectomy, to remove the fibroid in total. That is, by every sense of the word, a much more invasive procedure than what you guys are watching now. I've not cut the myometrium, I've not opened it up, my blood loss will be significantly different. And also, I'm gonna have to then suture that muscle, and that is a different compromise, and the reason that they are counseled towards cesarean. So for some patients, the thought of shrinking and leaving it in place and doing, honestly, truly, the least of the more minimally invasive of those two options is much more appealing to them. And for some patients, now speak on even the fertility seeking patients, they've had a myomectomy before, right? And we know there's a high recurrence of fibroids, as there can be for endometriosis, and we can debate that all day long too. These patients honestly don't want that option again. So I've been sent fibroid patients for radiofrequency specifically by fertility specialists because they do not want them to have to undergo another myomectomy. However, they have a symptomatic fibroid that either needs to be decompressed so they have better fertility options, or again, symptomatic relief, and they do not want to undergo another large procedure.
Thank you, Dr. Hawkins. We're gonna take one last question because we need to move along.
And I'm done.
But this is amazing. Thank you. You're like, this woman has totally had all her fibroids treated in the time we've been talking. So it's just wonderful.
My name is Radu. I have a question regarding my ablations. Over the years, people as old as me have seen different kinds of ablation techniques. And this is another one, probably safer and better. But my question is, we had some complications. One of them was necrosis of the fibroid causing a cystic degeneration and pain. And sometimes you got to go back and remove it. And we face the same problem with UFE, uterine fibroid embolization. And many fibroids somehow fall off. They're going to go retrieve it. So these are ablation techniques which were not exactly this, but different, but the result was the same. So the other thing, of course, as one of the doctors in the panel pointed out, that we don't know if it's malignant, not malignant, should we remove it, should we keep it inside? Those things are still up in the air, including radiologists. They don't know any technique by which they can actually determine that a fibroid is benign or not. Yes, we have our techniques, we watch and see if it's growing. There are some characteristics which are very typical of malignancy or pre-malignant fibroids. So I'm just wondering, I mean, I've had patients who had removal of the fibroid with morcellation. I had one patient who did develop leiomyosarcoma. Fortunately, I didn't get sued, but I'm just saying that these are things which happen when you remove a lot of fibroids. And I was wondering, Dr. Taraneh, as well as Dr. Hawkins, what your opinion is, and the panel too.
Absolutely. So I just want to start with fibroids affect 80% of all women around the world. So they're literally the most common gynecologic category that we see everywhere in the world. Of that 80%, which is billions of women, actually, 0.3% are cancer. So there is a rate of cancer. We have to use good judgment. We have to look at age. We have to look at characteristics on imaging. We have to look at clinical history. But again, it affects so many women that we can't treat it as cancer in everyone, right? So we have to have risk stratification. We have to know who's at most risk, and we have to use clinical judgment. So that's what I will say about cancer. That's how I treat it, because this is an issue that affects everyone. Like, it affects the masses as an epidemic even, but we don't recognize it as such. But so many women are affected. So that's one. The second part was about complications. So everything has complications. So I think that's a very good question. We always want to think about what are the complications for what we're doing versus the complications of the alternatives to what we could do. How do those play out? So Dr. Hawkins, what would you say about the complications of laparoscopic RFA? What have you seen in your practice? Because you've done now hundreds, and I know you're aware of the literature. So if you could speak to that.
Absolutely. So the most important part of this is to consider what we're actually doing, the pathology that we have and the way that it works. Again, this is a glycolysis process. It's not the same as the hypoxic process, where we're actually compromising pretty significantly the vasculature of these fibers. So we're not seeing that similar type of necrotic experience. And secondarily, I would not recommend radiofrequency exclusively for a pedunculated type 0 or type 1 fibroid. Is it impossible to do? No. Technically, you could kill the cells and get the cells to stop growing, but they would not shrink significantly because they need that myometrial approach. So I would remove them instead of necrosing them and then, yes, potentially leaving them to try to necrose and cause this difficulty in a different way altogether. So I 110% agree with Dr. Shirazian in that the workup of the patient is essential to help us stratify. So this patient had an MRI, even though the ultrasound was sufficient. She had an MRI, and she also had an individual biopsy, and we use all of the tools that we can to help stratify risk for these patients. And she was also counseled. Even her consent says that this possibly could be cancer. 110% am extremely cautious, especially in our older patients. And I explained to them, we're not going to have pathology when we finish it. Same as when patients have same as when patients have USD done. So when it comes to complications in the literature, the complication rates specifically for radiofrequency ablation is quite different than those even for myomectomy. Even when it comes to compromising other organ systems, I spoke to the ones you spoke of. We've not seen the same complications as with uterine fibroid embolization, even though this is an ablation procedure. And we've seen very similar outcomes when it comes to quality of life measures, as well as patients that are going to have diminished of their heavy menstrual bleeding, which was the primary indication for this procedure. So patients do quite well, and the complication rate is lower than any other ablative procedure that is done.
Okay, Dr. Hawkins, I hate to leave you because this looks like it's getting fun with endometriosis resection, but we have to join our next surgeon next. So we're gonna sign off. Thank you so much for your time. And for letting us be here. And it looks like you're resecting some endo here.
Absolutely, always get the endo.
Always get the endo, yeah. So I think instead of the slides too, because we're a little limited on time, we're gonna go straight into the next OR, because it looks like they're waiting.
Enjoy.
Thank you. Bye. See you soon. Okay, we'll pull up the slides for Dr. Crable and I'll set up that case. Oh, next slide. Oh, I have it, sorry. Okay, so next we're going to Texas to see Dr. Quanita Crable. She's a board certified OBGYN and she's been doing robotics for many, many years now. She actually proctors for Intuitive. She specializes in advanced minimally invasive gynecologic surgery using the Da Vinci robot system. She treats complex conditions, including fibroids, endometriosis, prolapse, etc. She's written a book on fibroids, and she's the founder of a foundation as well. And she's an advocate for women and speaks and talks about fibroids and gynecologic disease. So the case is a 35-year-old para 1, history of a vaginal delivery. She has heavy periods and is possibly also having endometriosis-like symptoms. She has multiple fibroids. She desires a myomectomy. I think that's it. So we're gonna go into the case now. Oh, wow. Alrighty. Dr. Crable? Can you hear us? It looks like we have quite a bit of fibroids.
Can you hear me?
Nice.
Can you hear me?
I can hear you. Can you hear me?
Yes, we got you. Well,
Yes.
so where are we in this case?
So
Can you?
I have a little bit of a delay.
Okay. What case
I'm
are
gonna walk you through
Yes.
what we saw when we came in.
Okay, perfect. And you can maybe set up the case too for us, because it
So-
may be different than what I said.
Yeah, this is a young lady who has stage 4 endometriosis. She had an attempted surgery by another surgeon in a different state who looked in and felt that it was too difficult and kind of closed her up. So she came to see me. We knew she had this large fibroid here coming off the top, but we also knew that she had stage 4 endometriosis. So here is this large fibroid, and I've been waiting to take this one off. So I'll take this off while we're on. And then I've just been doing some of the endo work, which has been a little bit challenging with this big mass in my way.
Yeah.
She had significant endo burden on her bladder, and then both of her ovaries were connected and kissing. I love the Raytech technique, so I have a Raytech in here just kind of helping me keep everything as clean as possible. Her appendix was involved as well, so we'll take this off. You can see here, it was completely stuck down to her right adnexa. So we'll take this appendix off at the end of the case.
Got
So I want to walk through the myomectomy, if that's okay.
Yes, please.
Show a little bit of technique on the
We would love that.
endometriosis. So what I do for my myomectomy is I always inject Pitressin at 4 and 8 o'clock, like a paracervical block down below. I do a hysteroscopy. And then when I come up above, I inject over the fibroid. And then I also inject over the, into the myometrium. We've also given Cytotec 600 micrograms, and then tranexamic acid, the anesthesiologist gives that prior to starting the case.
Is this a
So here we are,
pedunculated
so I'm gonna bring
fibroid?
in my Pitressin.
I can't quite see the base of it. It's
completely
pedunculated. Yeah.
Pedunculated because the base is, yeah, the base
Very
is too
broad.
wide to really call it a true
Yeah.
pedunculation.
It's a subserosal.
Yeah, so
Yeah.
we'll treat it like a regular fibroid. Yeah, subserosal, maybe a 507. So we're gonna inject into the myometrium at the base of this fibroid. I tend to just go in and out.
Anesthesia knows that we're injecting, so I'm not worried about anything here. We don't tend to have any issues with injecting our Pertressin.
Do you use TXA, Dr. Crable?
Yeah, okay, hold for a second. Yes, I'm sorry, at the beginning we gave TXA, so anesthesia gave that at the beginning of the case. I like this butterfly needle technique where I use extension tubing and I'm able to freely move around my needle without having to punch through the abdomen. So this technique is a lot more mobile for me.
And your section, every
All right,
time?
I think we got it.
I think, Dr. Crable, just so you know the setup here in Las Vegas, we have a panel in the front of the room too. So I don't know if you can hear them, but they'll be asking questions. And if you can't hear them, I'll ask the questions.
Yes,
Hello, great job, a nice case.
I can hear you.
I find interesting the way that you inject the vasoconstrictor. I was wondering if you suction every time that you change the puncture place to avoid to inject the vasopressin inside the vessel.
Do you pull back?
Yes.
Yes,
aspirate.
Back on the needle.
I don't have any issues with that. She does pull back some, but you see that I'm kind of going in and out with the needle. So it's like anesthesia is monitoring her closely, and I honestly have never really had any issues with that
Okay.
ever, honestly, in thousands of cases. So I know a lot of people worry about it, and that's kind of like what we're taught, but I do it so often. I really never have any issues with that.
And on the same note, would you be able to comment
You'll see here
on,
when I'm doing my myomectomy. Oh, go ahead.
yes, would you be able to comment on the dilution of vasopressin? I know everybody uses a different type
Of course,
dilution. So
yeah. For sure. I use 1 amp or 20 units in 60 mils of saline. And then I put 10 of those milliliters down below, and I use the other 50 up top. So right now we've only used 30 up top. So I have 20 left. If I need it. So we cut a little deep here, but we're in our plane. So one thing I like is I always make my incision horizontally. And then the second thing is you want to make your incision wide enough to get your fibrate out easily. So to me, those are my 2 biggest tips. And I heard a question come in while
Yeah,
I was talking.
I was actually going to ask the panel, Dr. Crable, about this idea of, sometimes patients go to one surgeon and then they look in and they don't do anything and they send them on. And if they have experience with that, because, I've definitely seen that in my practice where patients have, gone in to see a surgeon and they just look and they do nothing and kind of close. So I was curious about the panel experience. Anyone have that happen?
yeah, I mean, absolutely. I believe that most likely we've all seen those type of patients. But every case is different. Some cases do have a merit for not doing anything. For example, somebody that comes in through the emergency room in the middle of the night with acute onset of pain, and there is a concern based on symptoms, based on imaging studies, that person might have an axial torsion. And at that point, a diagnostic laparoscopy is performed that might show normal adnexa, but at the same time, they might find other pathologies such as endometriosis or large fibroids. And those are some of the cases that I do believe that do have a merit of not doing anything in acute emergency type of situations.
This is coming down beautifully.
Yeah.
Look at this, Dr.
Can I place a question?
Yes, it is.
I'm from Europe, but we have that issue concerning FDA related to the morcellation. And we know that in this uterine masses, there is always doubts, even if we do a nice preoperative imaging study with ultrasound and MRI. We have seen before a lady with 50 years old that radiofrequency was performed. In the US, there is room, or do you do in this suspicious cases biopsy of the masses, transabdominally or by vaginal transuterine way, or you don't do biopsies at all? Because now we know that sarcoma is a monoclonal mass. So if we get some histologic or even cytologic information before we decide for a myomectomy, like you are doing that. Now, how is it going in US?
How do you rule out cancer, I think is the question.
Yes.
Yeah, I just had a case like this. So I spent some time talking to my gynonc about that situation, and it's actually not recommended to biopsy anything that you find suspicious. So what I tend to do is I tend to do labs. I want to look at their platelet count. I want to look at their LDH, and then I get an MRI, and those markers help us determine if there's a level of suspicion. And then if we have a high level of suspicion, then, you know, for me personally, I tend to send them over to the gynonc. If I don't have any suspicion, then I'm going to do it the exact way I'm doing now. So you'll see bag management here. We're using an anchor bag here. It's a little bit bigger. I like this bag because it's easy to maneuver with. But you see my technique is just to lift the specimen up. My assistant came in under the specimen with the bag, and everything remained contained. So let me know if you have any questions about that, but that's what we tend to do here. The reason it came up, I had a lady who had lung mets, and she was told that they were benign, that she had benign, you know, fibromatosis to her lung. And so we were just discussing, like, you know, should we biopsy her? Because what the thought is if you biopsy through radiology, that it could spread the cancer. So he was telling me, no, don't, you know, that's not recommended.
I would say it's not commonly done.
Can I have a question, please? Well, thank you very much for your wonderful demonstration. I'm sure myself and everybody in the audience enjoying the wonderful dissection and peeling of the fibroid bloodlessly. But I have a special experience happened to me just the day before I came here to Las Vegas. I was doing also a myomectomy, and it was a terrible dissection. There is no plane of cleavage and extensive bleeding. And post-operatively, when I asked the patient about past history, she surprised me that she did before fibroid embolization, attempted fibroid embolization. So this made me to lose completely the plane of cleavage. I wonder if you have experience how to deal in such cases when you lose the GPS of plane of cleavage?
Yes, so
Did you hear that,
if you have
Dr.
something
Crable?
like that, or like an adenomyoma, yes, I heard it loud and clear. When you have like an adenomyoma, or sorry, give me just a second. That is the right fallopian tube peritoneum. When you have that, especially for an adenomyoma or endometrioma inside the uterus, is the best thing to do, or adenomyosis, is to debulk it as best you can. And so sometimes your plane isn't perfect, but if you can debulk it, the literature shows that these patients still tend to have relief, and they still tend to have higher pregnancy rates, as if more so than if you left it behind. So it is challenging. Trying to get into a plane that is less vascular does tend to help. And so I usually on those, if they're bleeding quite a bit, then I'll figure that I'm not in the right plane. So I have to find a better plane. This one was simple because it came out pretty easily. I got lucky today, but usually if I'm not in the right plane, it's gonna bleed a little bit more. The other thing I do is I have either my bipolar available to cauterize some of those or a vessel sealer. Just to the right, please.
Yeah, sometimes the fibers
Separate it a
are,
little bit, so.
sometimes the fibers are also necrotic, you know, there's sort of lots of reasons where we sometimes don't have great planes, but definitely that was a beautiful plane, which is why I commented on it earlier. You said she's 31?
Yes.
Or she's in her early 30s, this patient?
She is, yes.
Okay.
So two questions. One is.
And she wants to be pregnant.
Got it, right.
One would be if you were able to tell us your setup of the robotic ports. And then the second question, what type of endoscopic retrieval bag were you using?
Okay, yeah, of course. So I teach a lot more intuitive. So when I'm teaching, I like to tell people, especially if you're just starting out, use your fourth arm, but I don't practice that way. So you'll see that I'm using 3 arms only. So I have my Camran trocar, I have my number 1 here with my force feedback fenestrated bipolar, and then my monopolar scissors is in number 3. If I have a really large case like I did on Monday, then I'll use a 4th arm, okay? What I consider large is gonna be like 30 weeks plus. And so if I have that, then I'll use the 4th arm, and that 4th arm will go more lateral. I try to keep my trocars in a row. I don't try to do an M or any other, strategy. I like to keep my trocars in a row. That way I'm not fighting myself on the outside. It's definitely better with XI and DD5 to where you're not fighting with your other instruments as much. But you still can have that if they're, like if I put my scissors here and then my tenactum down here, I'm gonna fight on the outside. So I like to keep them lined up with each other. I use a gel port. So you'll notice that my assistant, I took out 2 medium-sized fibroids here and they didn't go into a bag. And that's because she pulls them right out through the gel port in real time. The bigger fibroids, we put them into a bag. I like 2 bags in particular for my large to medium or maybe even XL to large. I like the anchor bag. It can hold up to 3,300 grams of tissue. And so I like the anchor bag. When I get into my extra double XL or triple XL fibroids, then I'll go to the applied bag, the one without a stick. The reason I like the other bags because they come on a stick and they help with bag management and placing my tissue into the bag.
Okay, so what's up next? What manipulator are you using, Dr. Crable?
So
V-Care?
this is a delineator. I perforated at the beginning, so that was my fault. It's not my assistant, it's me. My tissues are a little bit friable with this endometriosis being here. Can you back up a little bit on that manipulator and try to go? Oh yeah, I'm not worried about it. We'll close it up. I started with the hysteroscopy. She didn't have any, she just had a thickened endometrium only. So because I was having some challenges getting to this ovary, I needed to remove this fibroid. So now you can see the endo here. She had kissing ovaries, so both of these were attached to each other. I already kind of freed some of this up. Her appendix was stuck right in here.
Okay.
So we freed that up, and we'll come back for that later.
Can I ask?
So here,
We have a
yes,
question
ask
from the
away,
panel.
please.
Dr. Nouri from Austria, congratulations to the very beautiful operation. I'm specializing in reproductive medicine. That's the reason
Thank you.
I want to ask a couple of questions. But before that, I want to go back to the question you asked regarding reoperation. So basically in Austria, what we try to do is difficult cases, one-touch operations. That means we have endometriosis centers, and there are also lots of work before the operation. Sometimes you have to inform more of the time, difficult cases, the general surgeons, urologists. So the idea is really one-touch operation for endometriosis patients. This being said, for this patient, I have a couple of questions. First of all, are you going to perform a perturbation of the tubes after the operation in order to see if the tubes are open, since you are now performing laparoscopy? And the second one, how long are you going to tell this patient not to get pregnant after this operation?
Yes, so my rule of thumb great question, by the way, when I do myomectomies, this patient had a HSG prior to the procedure. And so my rule of thumb is that I don't do chromotubation on myomectomies, because the fluid, even though this wasn't deep, it tends to seep into any hole that you have here. Yeah, so what I usually do is after 6 weeks, I'll repeat an HSG if she needs it. This lady, I would tell her 3 months to get pregnant, so she can start trying in 3 months. A lot of my patients get pregnant within that year, so sometimes we don't even get to do another HSG because they're not thrilled about doing another HSG because they're painful. So sometimes they'll try first, and then if we need one, if they're still not getting pregnant after a year or so, then we will go back and repeat those tests again.
And I think we typically say 3 months here, because the data suggests that 3 months is sufficient. So I was curious what
3 months to get pregnant.
Not to get pregnant.
3 months not to get pregnant until you can get pregnant. 3 months uterine recovery, if you will.
Yes, wait 3 months, then you can start trying.
Yeah, it was used to be like 12 months, then they reduced it to 6 months. It's interesting that you're saying 3 months. The next question is because of endometriosis, I see here, are you going to put her on agonists for 3 months or pills for a couple of months? I mean, basically, don't you think it's a good idea?
Of course. So here's the thing about the US. A lot of people don't want to be on hormone modulators. So that's one of the big issues that I have after cases like this is, trying to, I hate the word convince, but trying to suggest to my patient that that's the best option to get on something. I tend to like Orlissa or Lupron, but a lot of them don't want to get on anything. It's kind of sad, even though you tell them it helps to reduce recurrence. It helps with their symptoms to not come back so quickly. But here we have Dr. Shirazian, I don't know if you can speak on this, but we have a lot of issues with women not wanting to be on any hormones.
Yeah, I think for the most part, that's true. I think if she's trying for pregnancy quickly, we probably wouldn't recommend starting anything. I think if she's delaying pregnancy, I'll often encourage them to use just norethindrone or an IUD.
And do you do any MRI before allowing the patient to try the pregnancy, or ultrasound is enough?
I don't know that we have a
Ultrasound
norm.
is enough.
Okay.
You have them do an
For me,
ultrasound?
I just do ultrasound if she needs it.
Yeah, if she needs it.
No, not standard. But if she needs it, yes, I'll do an ultrasound. So this ovary is pretty.
So what's happening here? Yeah, the ovary looks.
At least I'm gonna try my best.
Just looks really messy.
What kind of cyst is that?
Yeah, she has a bad endometrioma here. So really, on my endometriosis technique, I do a lot of just kind of blunt dissection. You'll see me just pushing. The planes will kind of give themselves to you. So, not always, but typically, I tend to kind of find the plane and kind of work from there.
If we have any audience questions, if you guys step to the middle, I think Dr. Crable should be able to hear you, so we can take some audience questions.
Hi, Dr. Crable. Excellent deception. I love the way that you're doing this blunt dissection
Hello.
and sharp. And, but I was wondering, is there a corpus luteum cyst and you're trying to
Thank you.
save the ovary and ovarian follicles so that she can conceive on her own? Or you're trying to remove the cyst?
Yes, I'm trying my best. This ovary is pretty ratty.
Yes. It is. I need to suture it up too after
It's pretty,
removing the cyst.
it's pretty ratted up, but I can see good tissue here. So she'll have some good tissue. Hopefully they'll be able to work with it, but this is typically how I do my cases. A lot of my patients tend to get pregnant. Some of them need to use donors, but it's rare. We gotta get the cysts off. These are what's bothering her the most. And I try my best to save their ovary. Yes, she does have an endometrioma here and a corpus luteum.
Yes.
So I'm, gonna do my best to leave as much good tissue behind as I can. And yes, I will sew it after.
Yes.
Are you using two arms or three arms? If in this case, can be interesting to have a third arm, no?
I'm using, yes, it could. I'm very used to using my 3 arms. Can you suction that, Liz? But I have such a really good assistant.
Yes.
That she keeps me honest here. She's very good.
Beautiful
She's
dissection.
trying to not
Look
do
at that,
too much
that's
because you guys
beautiful.
are on, but usually she's moving all around and helping. Can you suction there?
Lovely. That kind of brings up an interesting question, actually. What about, this patient is young, but what about the use of like egg freezing? Do you have, I know in New York, we have many patients that sort of consider it prior to
Oh,
surgery.
yes, here too.
There too. I'm just curious if that's something that
Yes. Oh, for sure.
people come in wanting or asking about.
I have a lady that I'm gonna do next month that is trying to get her eggs frozen, but she kind of went too late, so we're gonna have to postpone her surgery if she decides. But yeah, I like to wait a couple months after the egg retrieval to do the surgery.
Very wise.
Yeah, that's coming off nicely.
Yeah.
May I ask another question? Do you
Yes, you
measure
can ask
egg
away.
in the cases that they want to get pregnant afterwards? Do you measure AMH routinely before the operation? Anti-Mullerian
I like
hormone.
to do AMHs prior. A lot of these women, yes, a lot of these patients are trying to get pregnant, so they have a full workup anyways prior to the surgery.
I have to say, I do it also.
Oh, yeah,
but
we'll measure them. I like to measure them after. Yeah, because endometriosis tends to lower their AMH. And then sometimes once you go in and clean all this up, it improves the AMH.
I will say the data for it is not great.
You want to try to get that?
And regarding fertility, there is now more acceptance
not
by IVF people to go for IVF in the presence of endometrioma. So we have an expert of IVF and a surgeon. So what is the situation of what are the limits and dedication to accept endometriosis and go for IVF?
I think we had a very nice question yesterday regarding to do first IVF or first operation. And we right now in medicine, the whole time we are talking about individualized medicine. I think in reproductive medicine, nothing is comparable with that. So each case has to be decided. So there is a lot of doing and procedures before you start these kind of operations in a patient. For example, the history, how long they want to get pregnant, sperm situation of the husband. Imagine the husband doesn't have sperms at all, azoospermia. So basically in this case, definitely a case that you recommend the patient to perform egg freezing before this operation, definitely. If she doesn't have a partner. If she has a partner, even IVF, and in these cases, we do 50-50. That means we freeze, if we get like 15 eggs, we freeze 7 of them for the patients, and we fertilize the other 8 and get hopeful good blastocytes. Is it a good answer to your question?
Here,
So egg freezing for all the stage 4, advanced stage, and
We recommended that again, if look at the AMH, if the patient is 40 years old and has an AMH of 0.02, what do you want to freeze? So very individual situation. So if this patient has an AMH of 2.5 and she's under 50, this is a good recommendation of egg freezing before the operation with a good conscience.
but also, I mean, there's the misunderstanding about AMH level. Is it only alone enough to judge fertility outcome, or some people talk about AFC antral follicle count together with the AMH, together with the age? So don't take only a one number as an indicator for fertility. So if you highlight this piece for them.
Yeah, thank you. This is exactly a very good point that you mentioned. We always do the antral follicle count, and there are cases that AMH is not high. Patients is under anti-baby pills if the patient is pregnant. So it shouldn't be the only marker. You have to put in reproductive medicine, it's like a PC computer, you have to put information, and then get an output on the situation of the patient. Very good point. Yes.
And here we're dissecting out the ureter.
Yeah, beautiful job.
Yes.
The ureter lies is on the right
Yes.
side.
Because of this here,
Yeah.
yeah, I wanted to follow and try to clean up this endometriosis here.
Very close to.
We use in some cases the ICG, the Firefly system for the ureter.
The rep here just asked me the same question. I don't tend to, because especially with DV5, like I love this camera. Like you can see how well I can see this ureter.
Beautiful.
Look how beautiful that is.
Yes.
And because the visualization is so good with this camera, I don't tend to have a lot of issues.
I agree with you.
Needing anything extra.
Yeah, we see it very clearly. Awesome.
And are we, the uterine manipulator, is it pushed up or it's just, is there any mobility there? Or
So
not really?
I have a young lady helping me, my tech. Yeah, there is now. If there wasn't in the beginning.
Okay.
But now, can you move the uterus kind of around, up and down?
Oh, yeah, now there is. Okay,
So
great.
we pretty much freed all this up already.
Yeah.
So I'm just trying to get rid of this here, this endo here.
Yeah.
So that's why I dissected out her ureter. So we'll go ahead and just kind of free up this peritoneum as best we can. This is where I do like my ray tech as well, the ray tech technique of cleaning this up. I need to put one back in. I took it out, it's a little bloody. But yeah, I like the visualization here, so I don't tend to do too much.
Yeah, you are using the energy also in the
Extra
very.
like ICG and all that.
For bleeding control, you use the.
Yeah, so the balance stuck up here. Go ahead, I'm listening.
For bleeding control, you injected vasopressin in the uterus, but we know that the half-life of vasopressin is quite short. You repair the uterus at the end, or do you use other measures to reduce the bleeding?
So this one here is not bleeding at all.
Yeah, but you don't use
Yeah,
the
this is not
tranexamic
bleeding at all.
acid.
Beautiful. So unfortunate. Oh, go ahead, I'm sorry, what'd you say?
You use also tranexamic acid or misoprostol in these cases? Yeah.
You said you
Both,
use both,
yes.
right, Dr.
I use
Crable?
both.
Yeah, she uses all of them.
Yeah, and so the other thing is, if it's bleeding, I will go ahead, like my case on Monday, I went ahead and took a fibroid out and then sewed the defect because it was losing a little bit more. So in order to reduce my burden of blood loss, I will go ahead and close up the incisions if I have to. So I gotta take each case for what they give me.
I have a,
Audience questions?
yes, this is Dr. Nezhat.
This is
First of
very
all,
big.
thank you very much for beautiful dissection and also showing the anatomy, untangling the difficult case. I appreciate if you show the inferior epigastric plexus nerve. I saw it lateral to ureter. We discussed it yesterday. I want to see the audience.
Can you suction here?
Yeah, medial to the ureter, you could see the fiber nerve going towards the pelvis. Yeah, this is the ureter, you could see.
If you can see now with all this blood here, I'm sorry.
Actually, when you lift up the peritoneum on the right side, exactly, below that one, you could see the fibers. You could see the fibers going down towards the sacroilium. Yes.
Yeah, let me see if I can get it cleaned up, I'm sorry. Can you clean up right here? Can you bring me a Raytech in, Sid?
Exactly, under your suction irrigator.
That way I can,
Yeah. The lateral to the rectum and medial to the ureter, you could see the fiber going down.
And one more concern,
Yeah,
when you have
let's see if we
such
can see it.
superficial oozing blood, okay, what is the role of the local hemostatic agents when you are close to the ureter and you're afraid of using energy? What options you can use for hemostasis here?
there's all kind of things that, I don't tend to use anything while I'm working real time though. I don't really have much issues. Dr. Shirazian, I know, uses different hemostatic agents. She and I had talked about this before, but I don't really tend to use much.
Well, what do you use
And
at the
so,
end, Dr. Crable? You use something at the end that,
I use at the end, yes, but I don't, like while I'm working, I like this Raytech technique. I mean, this has been a game changer for me. It really kind of keeps things clean. And if I'm really oozing, what I'll do, so this is a good tip, is I'll pack this here and I'll move over to this side, okay? And I'll clean this side up. And then by the time I come back over here, then, you know, it's not bleeding as much, it's not oozing as much. So at the end, I tend to like either Arista or New Knit. Obviously, I can't use that while I'm operating because then it'll obscure my view. But so in the middle of the case, I'm just using a Raytech, honestly, and my bipolar monopolar scissors.
We could inject pitressin here too. The same dilution which was mentioned, we could inject around this area some diluted pitressin during the procedure. That could decrease the bleeding and also decreases the possibility of using electrosurgery.
are you going to go to the other side now, Dr. Crable?
I can. I was gonna, because I can come back to this. Yeah,
Whatever you think.
let's do it.
I like the technique. That
No, let's
it's
look
very
at it.
important
So
to
she has
exercise
this
the
here.
endometriosis here. As you are doing, you exercise the endometriosis and the ovary, otherwise the ovary goes back and you continue to have symptoms.
I like the Raytech tech.
Right.
And so, actually, what do you put these patients on for pain
Yeah.
post-op? What, do you find they have a lot of pain?
Post-op,
Mhm.
post-op, I tend to use just Toradol, and I tend to use just Norco and Toradol. The reason being too, a lot of these ladies are suffering so much prior to the surgery that after I don't really have a lot of pain issues. A lot of them tend to say they feel better after the surgery.
Yeah. Do you use gabapentin?
especially with something like this. You know, someone had just told me about using gabapentin. I hadn't in the past, but I heard it really does help. Do you guys use it?
Yeah, we use gabapentin for everyone. We have a enhanced recovery pathway for really all of our patients, so everyone gets gabapentin to try and reduce
Every
narcotic use. Yeah.
To reduce the lesions, so which method or product do you use for the ovaries and for the uterus?
I use Intercede.
Intercede for the uterus, and for these ovaries, any anti-adhesion product?
Yes, I'll use the Intercede for that as well.
Okay.
Any other
I'm
audience
always open to
questions?
suggestions though.
Oh, yes, please step to the center. Wait, if you have the microphone, you can go ahead.
This question is pertaining to egg preservation and the disparity that is associated with it. I heard the doctor mention that she would counsel this person, if I could be wrong, about egg preservation. What are your thoughts on the disparity that's underlying egg preservation? It's more seem like a luxury than a procedure that to preserve women's.
It's expensive.
Yeah, it is very expensive.
So how do you counsel your patient when you're trying to preserve their ovary at the same time, trying to preserve their livelihood of when they conceive?
Honestly, so usually what I tell them is I know why I'm going in to do this surgery, right? It's so that they can get pregnant. And I usually use my expertise to say, hey, I've done so many of these cases. And so, you know, I ask them if they're going to go with me with surgery to trust my judgment. Because sometimes, like my case on Monday, not Monday. Yes, Monday. Today's Friday, right? My case on Monday, she had an obliterated ovary, obliterated fallopian tube. You can you're holding the ovary, just hold the ovary. Obliterated fallopian tube, and I needed to take it out. It was gonna do her more harm than good. So sometimes I'll talk to them about that. It's like, hey, if it looks like it's gonna do more harm than good, I'm just gonna go ahead and remove it. And usually they're okay, because I kind of explain, like, look, if there is a big, huge hydrosalpinx that I cannot reduce or fix, then, you know, it's going to cause that fluid to spread into the uterus when you're pregnant, and it can harm the pregnancy. I've seen that happen so many times, where I just need to go off and tie off someone's tube so that they can hold on to their pregnancies. I don't know if you all see that experience or have that experience, but that is something that I see quite often. A lot of times too, speaking to your point, is I work really closely with my fertility specialist. And so what I'll do is just have them go have a consultation with them. That's really important to me on a lot of these girls, is that they at least have seen someone for follow-up after the surgery.
Yeah, I think also, you know, egg freezing, yes, it's very expensive, is typically not covered by insurance. There are some companies, I think, that cover some egg freezing services for their employees, but in general, it's not covered. But we're also talking about a subset of women that may have reduced ovarian function. You know, we're not talking about everyone. So again, sort of just risk stratification and making sure women know their options. Like that this option exists, and you know, have them talk to the REI. And
I think I have to make a comment on that, and I think this is the most important thing, is that they have their talk with the specialist.
Yeah.
Because one thing is if they decide to do it, the other thing is our obligation as doctors to recommend this. And I don't see it as a luxury problem. This is a medical indication, definitely. In some countries, it's a very expensive, I know. In Austria, they don't cover it, so our patients, they have to pay for it for themselves. But interestingly, in Germany, they cover all costs for egg freezing, just for you to know.
That's great. We have a question here from the audience.
So say move to Germany. Nice.
Yeah, Germany.
Dr. Crable, thank you so much for sharing the surgery with us. It's magnificent. My name is Dr. Tiffany Dillard. I'm a mixed surgeon from Illinois. And my question is, what's your experience in pre-treating with Lupron for large fibroids or even for severe endometriosis? Do you find it helpful in shrinking before surgery, or do you find that it distorts planes? In what instances do you use it or not use it, and why?
So that's a great question. I get that question quite often, actually. I really don't want to use it if I can avoid it, because it does distort the planes. So I tend to only use it if someone is not going to have surgery. They want to wait, let's say 5 years, and that'll help me to suppress the fibroids from growing anymore. Hopefully, that's like the plan, right? I don't like them even to have a UFE prior to me doing a myomectomy. I would prefer to do it because my planes are a lot better when they don't have any of those things. I'd rather have a huge fibroid with great planes than a small fibroid with horrible planes and they're bleeding everywhere and it's a lot of the issues. So, because that kind of speaks back to what the other gentleman had asked as well. So I'm not for it, but I do use a lot of Orlissa, Lupron, and Myfembree. But I don't prefer to do it to like prepare me for surgery.
I actually do.
Nothing yet, Lynn.
Yeah, I do a little of for the big fibroid cases, I use the Myfembree pre-op, usually for 3 months prior to like large myomectomies. I don't know, my experience has been that it helps with bleeding. It also helps change it does change the consistency of the fibroid, but I haven't found that it really impacts my planes. So it just gives the added advantage of less bleeding, softer fibroids, easier to remove, faster operating time. I'm not chasing a lot of bleeding, but that's just been my experience with fibroids specifically though. Question?
Yeah, it's an opinion.
Yeah, I think it's everybody's. Oh, go ahead, I'm sorry.
First, congratulations for your surgery, Dr. Crable. It's an opinion for the panel here in the Congress. My name is Alejandro Baruch from Mexico, and we perform this type of surgeries in Mexico. What is about the fertility preservation or egg freezing. And in these cases, the problem is like the oocyte quality is not good in patients with this kind of endometriosis. And even if the patient goes to freezing, the quality is not good. We prefer to perform surgeries like this and then go to ovarian stimulation, and the oocyte quality is better. We talk with our embryologist, and the quality, the Istanbul criteria, is better when we perform this surgery. In the next Congress in the European Society of Human Reproduction, we are going to publish a cohort study in patients who have performed the egg freezing after the surgery and before the surgery. And the oocyte quality is better when we perform first the surgery and then go to the oocyte retrieval. And it's true, the anti-Mullerian hormone goes down, but the quality is better. And we are going to publish this cohort study of more than 200 patients that perform this type of surgery with endometriosis in stage 3 or 4.
Can I comment on that? There is a famous study by Carl Simon and Dr. Prether from Spain. Same concept, like you said, that the cross-oocyte donation, that they took oocyte from endometriotic ovary, compared it to oocyte from non-endometriotic ovary, and they found the same what you said, that the quality of oocytes is less from endometriosis.
Right, left posterior pelvic side wall.
Okay, I think, Dr. Crable, we're nearing sort of the end of the live. But is there anything else sort of want to tell us about next steps here, what you'll be doing?
Yeah, we're just gonna finish cleaning this up. I think we're pretty good here. I am going to just make sure I free up and restore anatomy as best I can. I'm gonna remove this appendix, and then we'll close this defect up here. And I think we'll be good to go.
Beautiful. And then she'll go home today.
I think we've restored pretty well.
Yeah, it looks wonderful.
She'll go home today, yes. Same day discharge, 2-week downtime.
2-week downtime. She'll go home with some
Yeah.
narcotics, potentially.
Is there a question, maybe you can repeat it to me?
Narcotics, Norco, and and ibuprofen. And then maybe I'll try the gabapentin thing. That probably is gonna help her with her pain department as well.
Yeah, we should give it a try. This is an amazing, amazing case, so difficult. And I mean, you just did such a beautiful job freeing everything up and showing us the anatomy. I know it was just fantastic. I think we have one last question from the audience.
I don't have a mic. Could you repeat this question? Because would she consider using ICG at this, IC indocyanine and green? Could she use it at this stage because she could not see the left ureter?
Would you like to use, the question is about ICG. Would you use it at this stage? I think she said she doesn't typically use it.
So the left ureter could not be visualized.
I'd like to, again,
Both ureters are freely peristaltic.
thanks again for nice demonstration. I just want to make one more comment about, as you mentioned before, that prior to
This one,
surgery,
I didn't show it. Oh, sorry. C-section in there. Go ahead, I'm listening, I'm sorry.
Go ahead, Dr.
yes, again, as you mentioned before, prior to surgery, you do thorough evaluation and consultation. So when we do the operation, you have uterus, you have ovaries, you have fallopian tubes. And now you want to see the future of this patient once you get pregnant, or she has done with the childbearing. We know that if the tubes are damaged, the bad tube is worse than no tubes. And now, since we know the fallopian tubes plays a very important role in ovarian cancer, majority of the what we thought high-grade serous ovarian cancer coming from the fallopian tubes. And the chance of the clear cell carcinoma and endometrial carcinoma also arising from endometriosis is more with the patient with endometriosis. So if the tubes are bad and the patient wants to get pregnant, we always ask this patient to do prophylactic salpingectomy. And I have published a couple of papers about it. So I'm glad you did the histosalpingogram. You could see the left tube looks very nice, the femur looks good. I am not sure how good the right fallopian tube is. So this is the practice that we do all the time. In this type of the cases that we consult the patient. And tomorrow I will show the data that we publish about the incidence. And again, in this case, you could see the nerve very well. You could see the lateral to the ureter, medial to ureter and lateral to the rectum. You could see the nerve going down very well. So I just want to mention when you, in this type of the cases, pure operative consultation is very important regarding what you do.
Yes, absolutely. Okay, I think I just wanted to wrap up with a few slides about RFA that I wasn't sure we would get to. Because there was a lot of questions about RFA.
I wanted to show this ureter.
Oh, there's the ureter, there we go. Very nice. Thank you, Dr.
I
Crable.
saw it in the beginning.
I knew you were gonna show it, so I wasn't.
Excellent.
I appreciate it, thank you.
You're amazing.
Thank you, guys. I had enjoyed going through this surgery, I appreciate it.
You're amazing. Not only is she amazing, she didn't even pick an easy case for us. You just had to pick the most difficult case possible? Okay, so I hope these two lives sort of represented a breadth of different types of options for patients. That's really what we were going with. So we had Acessa, where we showed the use of RFA, and here we had myomectomy and a section of endometriosis to kind of give a sense of the breadth of different choices and options. I was going to just put up to end, and then if there are any other questions, just a few slides, because I know that the Acessa is a relatively new technology. So just to kind of summarize so people are aware of the various types of RFA. Also, we had some patient questions, and I just wanted to make sure that I kind of close the loop on that. So this is a slide deck actually prepared by Hologic. I also have done some consulting work for them. Next slide. Oh, I do the slides. I'm sorry, I keep forgetting that. So RFA is sort of a response to this idea that women have waited many years for treatment for their fibroids, and sometimes access to skilled minimally invasive surgeons is limited. You know, often access to centers are limited. So RFA represents a tool that is more accessible potentially to more patients, also has good patient safety profile, is non-invasive, and allows people to recover more quickly. So it's incisionless. In other countries, which I don't know, again, if the panel here can advise on this, but they don't use general anesthesia. Sometimes they don't use any anesthesia. I met a GYN in Sweden who told me they just give local and patients do great and there's no issues. But here in the US, we do use general anesthesia. And it is a relatively short procedure in general. We saw the Acessa ablation that was done in less than an hour. Typically the same is true of the Sonata. So it's a minimally invasive option that kind of fits a procedural need for many patients. And there are two applications. So this is an image on the bottom left of the Sonata device. The Sonata goes in intracervically, so it goes in vaginally and then it's placed in the uterus. It has a tip. At the tip is an ultrasound. The ultrasound helps identify the fibroid sort of right in the cavity or in the myometrium. It actually can identify them in the subserosal pedunculated areas as well, but those are not best suited for Sonata. And I think Dr. Hawkins already addressed sort of how it works. But it basically heats the tissue. Through Sonata, the tissue actually is heated to a higher temperature than through Acessa. Acessa is 95, she says. And through Sonata, it's about 115 degrees. And the device helps you understand exactly the zone of treatment that you're treating. Again, that image on the left showcases the fibroid a little easier through the visualization, I think, than sometimes the Acessa does. And these are the fibroids that are indicated with the Sonata procedure. Someone asked this question. So typically, I personally think the fibroids that are 0, 1, and 2, even those 3, 4 locations are pretty good with the Sonata because you can access the cavity, you're within the cavity, and you can visualize all the fibroids either within the endometrial space or directly next to it in the intramural space. All right. Acessa tends to focus more on the fibroids that are in the outer layers, subserosal or pedunculated. Okay, that's basically all I wanted to highlight in this deck. Are there any other questions related to either RFA, myomectomy, endometriosis, fertility?
Any publication about the reproductive outcome after Sonata?
Yes. Do you want to talk to me? Or I'm happy to.
There
was a paper.
In fact, there is some publications, one in the Green Journal some years ago with very promising outcomes.
Yeah, the outcomes to date have been very reassuring. I think the largest study was about 187 patients who went on to get pregnant. And there was no increased risk of pregnancy-specific complications.
I also want to highlight that when we use these ablative techniques, radiofrequency, we have to control by ultrasound to avoid to damage the endometrium.
Yes.
That is the key because it is associated with the reproductive outcomes. If we ablate the endometrium, then we can impair the future fertility.
Actually, there is a way to basically put saline in the endometrial cavity through a channel in the Sonata device. So that's typically what I do. I will, basically place saline within the cavity so that we can see the fibers in the cavity.
Any assessment of the serosal temperature during this procedure, and anybody did measuring of how far the thermal spread goes?
There's a treatment zone, and then there's a peripheral spread zone that you see when the device is being used. I may have that somewhere in this deck. Here it is. See the green zone? The green zone is the area of spread. The red zone is the treatment zone. So you want both those zones to be within your serosal space, right? So as you're looking to see how large to make these zones, both the red and the blue, the red and the green need to be within the serosal.
Dr. Shirazian, before we finish the session, and I have one question and also one comment. First of all, thank you very much for excellent session, the moderator, the panel, and of course the surgeon. And my last question before the break is that, what is your experience using the Sonata for adenomyoma? Because you have extensive experiences and the panel, I appreciate it.
Yes, I have used them for adenomyomas. I've probably done almost 500 Sonata cases at this point over the years. I've been using it for at least 5 years now. I will say adenomyomas are tricky. I started using it hoping that we would get these really wonderful results where it shrunk down and symptoms completely resolved, but I have not really found that to be exactly what we see. I definitely think in treating the other fibroids, the bleeding decreases. So bleeding wise, it's helpful. Pain wise, I feel like it's probably not as helpful. We actually reviewed our own cases, 145 cases using Sonata, and we found that the women who needed us to do something else within 18 months of surgery were those who had endometriosis on MRI. So the adenomyoma is sort of in between. I think there is some benefit to Sonata with the adenomyoma, but may not be complete from a pain perspective. All right.
Okay.
Well, thank you all so much. I think we ended on time.
Thank you very much, Dr. Shirazian, a great panel, and also the surgeon. This was all the presenters. The whole purpose of us here is to have more endometriosis and fibroid and adenomyosis experts to do the care. So I am going to, and because so many of you, to see what would happen in the future, as Dr. Shirazian said, more than 1 billion women have all of these issues. There are not enough surgeons. The good news that I give you, and the break is going to be 30 minutes from now, because so many of you have asked this, so I'm going to give my presentation now. Go ahead, and the presentation that I will give you is going to be very good news for everybody. You will see in the future, good news, every one of you, from the surgeons, the students, patients. The future is very bright. Why? And that is why we have started American Global College of Endometriosis Specialists. And as I said, Dr. Shirazian somehow mentioned, there is about almost 1 billion women, actually close to 1 billion women endometriosis, and with fibroids could be a lot more, significantly more. So at the present, there are no guidelines, there is no standards, and almost every OBGYN claims that they know about endometriosis and they can treat it. But we do know that when there is a specialized care, for example, patients, they receive better care. There is American Society of Colorectal Surgeons, there is American Heart Association, there is Society of Gynecologists, Oncologists. And all of these societies, specifically comparing to patients that they are not treated by everybody, their care is better. So patients that they are treated, for example, by Society of Gynecological Oncologists, they receive better care than they receive from their standard. In the United States alone, there is only 100,000 cancer, only 100,000, and there is a society called Society of Gynecological Oncologists. As I said, at least in millions of patients with endometriosis, and there is no specific care. Endometriosis is not only a disease of reproductive organ, it's a whole body disease. So this society that we started, the goal is to do the same thing for patients with endometriosis, fibroid, and adenomyosis. And how, and again, I have some engineers here too. AI, the way that I see it, is going to really make this care significantly facilitated in many, many ways. And why? Because at the present time, when you give aspirin or Tylenol to the patient or amoxicillin all around the world, it is the same care. But surgery is not the same. Surgery, even in 2 OR, in two sites, doing, for example, myomectomy or endometriosis in 2 rooms in the same hospital, the treatment is different. The care is different. 2 surgeons, they do differently. The nurses, the environment, the anesthesia, all of them, they do different. So we have to standardize surgery all around the world. And this is going to happen. Why? Because right now, if the population of the world is 8 billion, only 5 billion of them, they don't even receive care. They do not have enough surgery. That means at least there's 143 million surgeries needed every year. There are people, 19 million of these people are dying every year because they have access to no surgery at all. And we do know that low-skilled surgeons have 3 times the complication rate and 5 times the mortality rates compared to the high-skilled surgeons. Inexperienced surgeons have 2.5 times the operative time and 6 times the readmission rate compared to experienced surgeons. So how can we really democratize and standardize surgery? The only way is at the present time is with artificial intelligence, virtual reality, and so on. Because the power of the computing significantly increases. Significantly, the power of computing is increasing. At the present time, the power of the AI is for sure in many, many aspects has passed the power of the one human being. If you look, for example, in the level of the artificial intelligence, there are 4 levels. These 4 levels are very simple. The level 1 of artificial intelligence is simple level of pattern recognition. We already do this. There is the Google's Mo0 chess game. It has done so well that the chess game of the artificial intelligence in Google plays by itself. Without even knowing the rules, it has completely surpassed any human being to being able to think that way or pass that way. So I didn't even know the rules. That is already in place, pattern recognition. And that is one area that is very simple in many aspects. Already in medicine has started in many aspects for dermatology and for radiology. A lot of diagnostic radiology is done, and the AI can do it much better. Then the level 2 is reactive machines. Self-driving cars, you see it every day already. Already you see it. And ChatGPT, Cloud, Gemini, Perplexity, so on and so on. They do a much better job. Anybody, all of you, I'm sure you are using them. They are much faster than any person could write letter for you. They think many things that you don't even think about it. Just tell them exactly until you ask them, good question, how you want your letter to be written, politely, coarsely, straightforward, and ask him what is your reason. You are doing that, and if your reason makes sense to you, they do a much better job. So you can see a lot of times, even in medicine, these bots, they can do a better differential diagnosis than a lot of time yourself. You are very, very smart, and your doctors usually are the smartest group of people traditionally, with good high IQs that they went to medicine until very recently. So you can see that area is already smarter than you, one person. At least, and I will tell you again, and when that level passes to the fourth level, that I showed you the singularity, how the robots are learning from themselves, I am afraid you might not, but you are young, you will see. In the next 30 years, some of these levels are much, much smarter than any human being, and they will learn from themselves, and they are going to take over, and they would be able to do surgery as well, the same way. So you can see for diagnostic radiology, as I told you, it has better diagnostication. For benign dermatology, pattern recognition, and then because it's on the skin, the surgery is going to be done much easier by the robots. Robots, they do not get tired, they don't have moods, they don't get upset, they don't have, they don't care, only they have to do their job. And they can do it for everywhere, every place. And they are not worried about the weather, or if they have a fight at home, or if they have sad news come to them, or if they have a cold. So it is going to start at the level first with the dermatology. It is very simple. We are already working on it. And benign dermatology with the robot, it could be much precise, much more delicate. And then after benign dermatology is malignant, moles or things like that, simple. After the skin, we go to the next level. The next level is joint surgery. Joint surgery by orthopedic surgeons. The robots can do a much, much better job, again, but for the same reason. One thing that you have to remember, there was in one area, Porsche car company was going bankrupt. But they found out if they hire robots to do their paintings, they noticed that the painting of the robot is better than the painting of the average painter. However, the robot still was inferior to the best painter in the top. The same thing is going to be for surgery. at least at the very beginning. As we learn, the robots are going to do, and they are going to be better than the average doctors, the average diagnostician, and the average surgeon. But they would not match the top yet, unless, because the top surgical level has become like an artistry. It becomes spontaneous during the surgery. You can create. You are the outliers. Still the robots wouldn't know until we get to the level 4 that the robots learn from each other. So this is already is going, and as I explained it for you. Then after the skin and the joint, we go gradually inside of the abdomen. Inside of the abdomen, we would start with simple procedure that robots would take over, like appendectomy, cholecystectomy. That is, it is easier. The variation, the variability is not too much. So that is going to be the next step. When this would happen, as I said, this already has started, for example. As I said, you can go ahead to the chat GPT, to Gemini, to Cloud, to Perplexity, and do all of that. But before they were launched, we were also ahead of the whole thing. In 2019, we started the Nezhat endometriosis risk advisor app that with more than 95% accuracy could diagnose endometriosis or could tell you the risk of the patient. It doesn't diagnose it. It's a risk advisor app. It is something that we developed years ago. It cost a lot of money because of the we have been publishing about the future of the surgery before it became popular right now. We had predicted our publication beginning about 6 years ago that we said that ultimately surgery is going to be done by robots and robot assisted, not in the form of right now that we are using a computer assisted. The robots will be doing the surgery and the diagnosis and the hematology, as I said, and for example, the risk advisor app that it is based on AI and it is published already, and we are updating it, and it has been downloaded at least 300,000 times, and you can download it for you also. Lucas Nezhat is going to be presenting an update on it on 360 tomorrow, or I don't know, perhaps today, later. But while you are here, all of you simply go ahead and download it on your app and test it. You can see for pain or infertility, and we have tested it on thousands of the patients. It is quite accurate. And what it has done, it has made it completely free. All over the world, this app is free. So more and more medical people would come, and that is the way that gradually you would standardize and democratize medicine for millions of patients around the world that they cannot receive it even right now. People in Africa, in South America, in China, everywhere, they can go to ChatGPT, Cloud, Gemini, as I said. They would put their symptoms, it would guide them, and a lot of time does a much better job diagnosing the disease than the physician, than the average physician. That is a reality. And you should accept it, you should accept it. They are not going to take the job of the people. Still, there is not enough people to take care of patients. The jobs of the physicians would be to work with these apps, with these bots, with this intelligence, and enhances their work. So this is going to happen. This is going to be the way that this is going to be the future of surgery. I'd like to thank all of you for asking me to give this talk. I am happy if you have any questions. I try to be as fast as possible to do this in this 15, 16 minutes. But because it was any question, if you are happy, I would be happy to answer. And then otherwise, after that, we go for the break. Any question? Thank you for attending. Thank you for all of you coming here. Please let's go ahead and have a break, and you're all available. And also, I thank every single one of you. And because I have the moment while you are here, the scientific committee of this the society, with every one of them, I don't want to mention one by one, but Dr. Shawki is here, Dr. Wad, Dr. Taraneh Shirazian, Dr. Pejovic, Zahra, many of you have been here, and also the organizing committee. They have been great. The whole Kenneth group, I like to thank them. They have done an outstanding job. As I said, we had about 300 registration people, but a lot of, about 100 of the badges are there that they come and go. So that is Dr. Wall, that has been part of the organizer from the very beginning. Also, one of the people who is not here has done a lot for Endomarch for the past 14 years. And unfortunately, her brother died recently, Barbara Page. We would like to acknowledge her. Her brother was a young man, not too old, and unfortunately, recently had a heart attack. So we want to acknowledge her and her contribution. And all of the other students, all of you are here, Nana, and Zahra, and again, every one of you. So I'd like to acknowledge all of them when you see them. And thank you very much again.
Okay. We appreciate if you guys go ahead and, ladies and gentlemen, go to the exhibit hall and communicate with the representatives that they have.